Welcome to Nursing 200, Unit 2, Management of Patient with Fluid, Electrolyte, and Acid-Base Imbalances. Homeostasis, or fluid and electrolyte balance, is required for all body systems to function properly. The body systems consist of intracellular fluid and extracellular fluid. Intracellular fluid is found within the cell. Extracellular fluid is found outside of the cell. Total body water equals 60% of a patient's body weight. Intracellular water makes up 40% of body weight, and extracellular water makes up 20% of body weight. In the extracellular fluid, interstitial fluid is approximately 10 liters, plasma is approximately 3.5 liters, and transcellular fluid is approximately 1 liter. The pathophysiology of fluid, the regulation of fluid and electrolyte balance consists of several properties. 1. Osmosis, which is the movement of water caused by a concentration gradient. Tonicity is the ability of all the solutes to cause an osmotic driving force that promotes water movement from one compartment to the other. Diffusion is the natural tendency of a substance to move from an area of higher concentration to an area of lower concentration. And renal filtration is the net movement into or out of the capillary due to pressure differences, most often from the kidneys. There is a nice link here to the sodium-potassium pump, which is also something you should view. This slide shows osmosis, and it shows that low solute concentrations often move to high solute concentrations through a semi-permeable membrane. Diffusion is an area of high solute concentration that moves to an area of low solute concentration back and forth and again through a semi-permeable membrane, which means that the membrane itself actually has small holes, if you will, that the fluid and particles can travel back and forth through. Routes of gains or losses of fluid and electrolyte balance in patients are closely linked to or affected by electrolyte concentrations, and they're regulated by the kidneys in urine output, skin in sweat, fever, and burns, and lungs in the respiratory rate. Dry climate increases losses, and the GI tract, such as the conditions of diarrhea. Nursing diagnosis related to gains and losses in fluid volume include fluid volume deficit and fluid volume excess, and they're often related to various medical conditions and result in a lack of or an excess of fluid in certain medical conditions. Laboratory tests for evaluating fluid status include osmolality, the concentration of particles per kilogram of water. Serum osmolality, or the osmolality found in the blood, is the concentration of particles, sodium and protein particularly, in the plasma. The normal is 275 to 295, and an easy way to remember osmolality is to remember that if they're high, they're dry. Urine-specific gravity measures the kidney's ability to excrete or conserve water, and it's an inverse relationship with the urine volume. In other words, if you have a large amount of urine, you're going to have a low specific gravity, and if you have a low amount of urine, you're going to have a high specific gravity. Normal specific gravity of the urine is 1.010 to 1.025, and the urine specific gravity is almost always measured when a patient has a urinalysis. Other laboratory tests for evaluating fluid status include the BUN, or the blood urea nitrogen. It's the end product of protein metabolism by the liver. The normal is 10 to 20, and it increases in renal failure, dehydration, fever, and sepsis. Creatinine is another basic fluid laboratory test for evaluating fluid status, and it's the end product of muscle metabolism in the body, and it's also the best indicator of renal function in your clients. Normal creatinine is 0.7 to 1.4 milligrams per deciliter. Hematocrit, measured in the CBC, is also another valuable fluid test for evaluating fluid status. It measures the volume percent of red blood cells in whole blood, and it increases in dehydration states. Males and females have different hematocrit levels. The normal in males is 42 to 52%, and in females, it's 35 to 47%. Question: an ICU nurse has orders to infuse a hypertonic solution. This solution will increase the number of dissolved particles in the patient's blood, creating pressure for fluids in the tissues to shift into the capillaries and increase the blood volume. What term is described by this process? Answer: Osmosis. Osmosis is the movement of fluid from a region of low solute concentration to the region of high solute concentration across a semi-permeable membrane. Hydrostatic pressure refers to changes in water or volume related to water pressure, and active transport is the movement of molecules against the concentration gradient. Diffusion is the movement of solutes from an area of greater concentration to an area of lesser concentration. Other homeostatic mechanisms. There are several organs involved in homeostasis, including the kidneys, Several organs are involved in homeostasis, including the kidneys. They regulate extracellular fluid volume and osmolality by retaining or excreting certain body fluids. They regulate electrolyte levels in the extracellular fluid by retaining or excreting unneeded substances, and they also regulate the pH of extracellular fluid by retaining hydrogen ions or bicarbonate. The heart circulates blood through the kidneys to allow for urine formation. The lungs increase their respiratory rate, and ventilation can cause changes in fluid and electrolyte statuses. Approximately 400 milliliters of water daily is removed by the lungs. So always keeping in mind respiratory rate, that patients will have decreased fluid volume status with increased respiratory rate because of the amount of water that is removed during respiration. Other homeostatic mechanisms include pituitary functions. The hypothalamus manufactures ADH, or antidiuretic hormone, and it's stored in the pituitary gland. ADH is a water-conserving hormone stored in the pituitary, and it causes the body to retain water. Another easy way to remember the function of ADS is if you look at the initials A, D, which stand for add, and the initial H for H2O, which means add water. In other words, add water to the body or retain. Adrenal function has several other different types of hormones. One of them primarily is aldosterone. And the way to remember adrenal function is remember that A, adrenal, and aldosterone both start with A. Aldosterone increased secretion of aldosterone causes sodium retention, water retention, and potassium loss. Another chemical or hormone regulated by the adrenal gland is cortisol. And cortisol can produce sodium fluid retention like corticosteroid therapy does. So if you can remember that steroids make people big and puffy, cortisol is the main ingredient behind that and can cause that same sodium fluid retention, just like the medication. Other homeostatic mechanisms include parathyroid functions from the parathyroid gland. The parathyroid glands and the thyroid gland regulate calcium and phosphate with parathyroid hormone. Parathyroid hormone, or PTH, influences movement of calcium out of the bone to the blood, calcium absorption from the intestines, and calcium reabsorption from the renal tubules in the kidneys. Baroreceptors detect changes in pressure within blood vessels and transmit those changes to the central nervous system. They activate parasympathetic and sympathetic nervous system mechanisms, and remember, your sympathetic stimulation is your fight or flight, which will result in increased blood pressure, heart rate, and those types of things. Increased circulating blood volume due to renal artery constriction, and increases in sodium and water reabsorption and potassium loss. ADH, oral intake, is controlled by the thirst center in the hypothalamus. And osmoreceptors, located in the hypothalamus, sense changes in sodium concentration, and they stimulate the release of ADH to dilute extracellular fluid to maintain normal sodium concentration. The renin-angiotensin and aldosterone system is an important homeostatic mechanism. Angiotensin II is the most potent vasoconstrictor in the body. It constricts small arteries and veins, increases peripheral resistance and blood pressure, which is one of the main reasons why angiotensin ACE inhibitors are often indicated in patients with cardiac problems or MIs. Because this increase in peripheral resistance and blood pressure puts a stress on the heart, the angiotensin II blocker or ACE inhibitor slows the heart rate down and decreases that peripheral resistance and blood pressure, thereby resting the heart. Angiotensin II also constricts the size of arterioles in the kidney nephrons, which further decreases GFR, or glomerular filtration rate, and reduces urine output to prevent further loss of water. Angiotensin II then secretes aldosterone, the water and sodium-saving hormone, which allows more water and sodium to return to the blood, increasing blood pressure and increasing blood volume. All of these actions maintain perfusion to vital tissues and organs, but sometimes can be problematic in certain patients. Atrial natriuretic peptide, or ANP, is released by muscle cells of the atria. Any condition that results in fluid volume expansion, hypoxia, or increased cardiac filling pressures, atrial tachycardia, heart failure, renal failure, increase the release of ANP. It's the opposite action of the renin-angiotensin-aldosterone system. ANP decreases blood pressure and decreases volume. This following slide shows the regulatory process of many of the different types of hormones in the body, and it's important to understand how this works, so you may want to study this. This next slide shows the significance of fluid imbalance in certain patients and how the renin-angiotensin system regulates the maintenance of adequate tissue perfusion in the patient. Hypovolemia. Causes of hypovolemia include hemorrhage, nausea, vomiting, and dehydration, burns, severe wounds, diuretic therapy, renal failure, and fever. Trauma patients often present with hypovolemia. A critical history is very important on these patients as we know how to understand how to treat our hypovolemia and also what can cause the problem so we can treat it effectively. Physical assessment and clinical manifestations include the cardiovascular system, increasing heart rate, low blood pressure. Heart sounds are critically important in these patients. The skin might look dry, flaky, and tented, dry mucous membranes, and flattened neck veins. Remember, the tenting of skin in the elderly patient is often not an adequate way to assess their volume status, as their skin is thin and may tent even though there's a lack of volume. Neurologic status, mental status changes, altered level of consciousness. Assess your patient's neurologic system carefully. Renal, dark amber, urine, strong odor urine. Labs, you want to include urine-specific gravity, so solutes less than 1.020, increasing urine osmolality, remember, when they're high, they're dry, and elevated hemoglobin, hematocrit, BUN, and electrolytes. Treatment of hypovolemia usually consists of isotonic or hypotonic IV solutions, and we'll talk more about those in class. Hypervolemia causes excessive fluid replacement, kidney failure, congestive heart failure, long-term corticosteroid therapy, SIADH, which is a condition where increased antidiuretic hormone produces excessive thirst, and excessive thirst. Physical assessment for patients with hypervolemia and clinical manifestations include assessing the cardiovascular system, increasing blood pressure, bounding pulses, elevated central venous pressures, and elevated pulmonary artery wedge pressures. Respiratory auscultation reveals crackles. Skin is distended neck veins and hand veins, pitting edema, and neurologic consists of altered level of consciousness. Interventions for hypervolemia include monitoring for patient safety, monitoring for pulmonary edema, drug therapy, nutrition therapy, and strict monitoring of intake and output on an hourly basis. Treatment for hypovolemia includes diuresis and fluid and sodium restriction. Common IV solutions. The choice of an IV solution depends on the purpose of the solution. Solutions are categorized as isotonic and include solutions such as D5 water or 5% dextrose in water, 0.9% normal saline or normal saline, and LR, which is lactated ringers. Remember, lactated ringers has a small amount of lactate in it, which will help buffer the body system. Hypotonic solutions such as 0.45% sodium chloride or half normal saline, and then your hypertonic solutions such as 3 and 5% sodium chloride. There's a nice YouTube video on the common IV solutions and their uses listed in the PowerPoint that you may want to view. Pop questions. What is the nurse's primary concern regarding fluid and electrolytes when caring for an elderly patient who is intermittently confused? Answer. A. As the adult ages, the thirst mechanism declines and is not appropriate. Adding this in with a patient with an altered level of consciousness, there's an increased risk of dehydration as often these patients forget to drink or don't have the appropriate mechanisms to stimulate thirst. Next question. A patient experiencing multi-system fluid volume deficit has the symptoms of tachycardia, pale cool skin, and decreased urine output. The nurse realizes these findings are most likely a direct result of which of the following problems? A. The internal vasoconstrictive compensatory reactions within the body are responsible for the symptoms exhibited. The body naturally attempts to conserve fluid internally specific for the brain and heart, which are the major organs of the body. While monitoring a patient who has fluid overload, the nurse would be most concerned about which assessment finding. D. Fluid overload may lead to pulmonary edema and heart failure. Crackles in the lungs for a patient are a problem. Any patient with fluid overload, regardless of age, is at risk for these types of complications. Older adults or those with cardiac problems, kidney problems, pulmonary problems, or liver problems are at greatest risk. The presence of crackles may be indicative of pulmonary edema, which can occur quickly and lead to death in patients with fluid overload. An elderly patient does not complain of thirst. What should the nurse do to assess that this patient is not dehydrated? C. The first mechanism declines with aging, which makes older adults more vulnerable to dehydration. The nurse should check the patient's urine osmolality as a first step in determining hydration status before other detailed and invasive testing is done. And again, remembering that when they're high, they're dry. Now we'll review the specific electrolytes themselves, starting with sodium. And remember, the chemical name for sodium is capital Na. The normal level of sodium is 136 to 145 in the serum. It's the major electrolyte in extracellular fluid. Where sodium goes, water follows is always a good thing to remember. The sodium level is vital for skeletal muscle contraction, cardiac contraction, nerve impulse transmission, and normal osmolarity and volume of the extracellular fluid. Sodium problems can be caused by active losses or by dilutional hyponatremia, in which the body has too much water in the vascular space, which dilutes the actual serum sodium. Clinical manifestations of sodium depend on the cause, magnitude, and speed of the deficit, and it may necessitate fluid restriction or sodium replacement IV, depending on the situation. And in this slide here, it's just a couple of different things to remember about hyponatremia and where all the sodium goes. Hyponatremia is a serum sodium that's less than 136. Actual hyponatremia is salt loss that is greater than water loss, and causes of it include lack of sodium intake in the diet, vomiting, diarrhea, fever, diaphoresis, overuse of diuretics, adrenal insufficiency where there's a deficiency of aldosterone. The signs and symptoms associated with hyponatremia include fluid volume deficits, tachycardia, rapid thready pulse, dehydration, decreased CVP, decreased pulmonary artery wedge pressure on your swan, dry mucous membranes, increased hematocrit, weight loss, oliguria or poor urine output, low blood pressure, lack of skin turgor, altered mental status, muscle weakness, spasms, cramps, and decreased serum osmolality. Again, remembering when they're high, they're dry. So if their sodium is low, then they're hyponatremic. Interventions include IV normal saline. If it's a severe case, 3 to 5% hypertonic saline is used. This is only used in very, very severe cases, and most of the time you start with 3% hypertonic. IV normal saline oftentimes is given. However, another more appropriate way too is often restricting fluid. It's really hard to correct a severe loss of low sodium by infusing IV fluid, because as you put the IV fluid into the body, oftentimes you cause a rebound dilutional hyponatremia. And again, remember, do not increase the serum sodium by greater than 12 milliequivalents in 24 hours. And severe cases of hyponatremia, hypertonic saline often isn't indicated until the patient has about 120 to 122 serum sodium. Dilutional hyponatremia is when the sodium is normal, but it's diluted with large amounts of water, and causes of this can be congestive heart failure, liver cirrhosis, excessive water intake such as polydipsia, infusion of increased amounts of IV solutions, inappropriate secretion of ADH, and where you have SIADH, which is an excess secretion of antidiuretic hormone, Excess fluid volume will dilute the serum sodium, and this can be caused by meds, malignancies, postoperative states, and drug use such as street drugs, often ecstasy use. This is associated with a fluid volume excess, and again, the patient shows the same types of signs where they get weight gain, edema, increased central venous pressure, increased pulmonary artery wedge pressure, jugular venous distension, elevated blood pressure, low urine output, crackles, cerebral edema, lethargy, confusion, muscle twitching, and seizures. And again, interventions here include fluid restriction, monitor I&O, monitor the serum sodium, monitor for any level of consciousness changes, and seizure precautions. You want to restrict these patients with water, 800 milliliters in 24 hours. And medications useful in promoting fluid excretion without excreting sodium. For SIADH patients, it's lithium, which antagonizes the osmotic effect of ADH on the medullary collecting tubule. Hypernatremia, caused by a gain of sodium in excess water or by a loss of water, which is cellular dehydration. Causes include renal failure, excess sodium intake, corticosteroid administration, which causes a retainment of sodium and excretion of potassium, Cushing's syndrome, which triggers the retention of sodium, dehydration, and diabetes insipidus or age-related changes. Signs and symptoms of hypernatremia are primarily neurologic: restlessness, weakness, disorientation, delusional ideas, dry, swollen tongue, sticky mucous membranes, flushed skin, peripheral or pulmonary edema, postural hypotension, increased muscle tone and twitching, decreased DTR or deep tendon reflexes, tachycardia, oliguria, increased specific gravity, and increased serum osmolality. Interventions include hypotonic solutions, least amount of solute concentrate, reduce processed foods and dairy products, and then desmopressin or DDAVP, which is synthetic antidiuretic hormone, and treat diabetes insipidus if it is the cause. For which of the following electrolyte imbalances should the nurse monitor a client who has an NG tube with suctioning? Answer C. NG losses are isotonic, containing both sodium and potassium, and so the patient is at risk for both hypokalemia and hyponatremia. An elderly patient comes into the clinic with complaints of watery diarrhea for several days with abdominal and muscle cramping. The nurse realizes that this patient is demonstrating symptoms from which of the following electrolyte imbalances? B. This elderly patient has watery diarrhea, which contributes to the loss of sodium. The abdominal muscle cramps are manifestations of the low serum sodium level. A patient is diagnosed with severe hyponatremia. The nurse realizes this patient will most likely need which of the following precautions implemented? B. Severe hyponatremia can lead to seizures. Seizure precautions such as a quiet environment, raised side rails, having an oral airway at the bedside, and padded side rails would be included. The nurse is planning care for a client with fluid volume overload and hyponatremia. Which of the following should be included in this client's plan of care? C. The nursing care for a patient with hyponatremia is dependent on the cause. Restriction of fluids to 1,000 milliliters a day is usually implemented to assist sodium increase and to prevent the sodium level from dropping further due to dilution. A patient with fluid retention related to renal problems is admitted to the hospital. The nurse realizes that this patient could possibly have which of the following electrolyte imbalances? B. The kidney is the primary regulator of sodium in the body. Fluid retention is associated with hypernatremia. Potassium. Normal potassium level is 3.5 to 5, the main component within the cells, the intracellular fluid of the cells. Most potassium is eliminated and regulated via the kidneys. When potassium levels are elevated, a release of aldosterone, sodium and water-saving hormone, is stimulated. This triggers the excretion of potassium in the urine and retention of sodium until the potassium returns to normal. The major assessments for a patient with potassium issues are the cardiac, respiratory, and muscle signs and symptoms. Again, here's a slide showing serum potassium issues and some of the problems that can happen. Hypokalemia is a state in which the serum potassium falls below 3.5 milliequivalents per liter, and it's caused by active losses of potassium or insufficient intake. Causes include increased output of potassium due to overuse of diuretics, antibiotics, diarrhea, vomiting, gastric suction, recent ileostomy, intestinal drains, prednisone and corticosteroids, which retain sodium and excrete potassium, and decreased intake of potassium, which comes from being NPO, anorexia, vomiting, alcoholism, and fasting diets. In hyponatremia, the low sodium stimulates aldosterone production, which signals the kidneys to retain sodium and water, and to excrete potassium. IV insulin also plays a role in hypokalemia, as IV insulin promotes entry of potassium into skeletal muscle and the liver cells, thereby dropping the serum potassium level. Signs and symptoms of hypokalemia include weak respirations, hypoventilation, hypoactive bowel sounds, constipation or paralytic ileus, arrhythmias, increased sensitivity to digitalis, and risk for toxicity, ST depression, flat or inverted T waves, U waves, and dysrhythmias. And remember, the hallmark of hypokalemia is usually PVCs, or premature ventricular contractions, and the initiation of VTAC. Again, this shows the normal EKG, and it shows a patient with hypokalemia and hyperkalemia. In hypokalemia, the T wave is often flattened, and in hyperkalemia, the T wave becomes peaked and tall. Remember, one thing, diuretics are important if needed, and one of the most common ones that we give is spironolactone. Hyperkalemia. Hyperkalemia is a potassium level greater than 5 milliequivalents per liter. It results from increased intake of potassium, medication effects, musculoskeletal injury. Trauma patients often present with hyperkalemia, as the musculoskeletal injury drops large levels of potassium into the serum, or decreased renal excretion of potassium. Hyperkalemia produces significant cardiac and GI manifestations. 1. Decreased or impaired potassium excretion in acute or chronic renal failure is the most common. Potassium-sparing diuretic overdose, such as spironolactone, Addison disease, and hypoaldosteronism, which is an aldosterone deficiency, loss of sodium, and retention of potassium. Additions of potassium into the extracellular space can happen with PO or IV potassium supplements, cell injuries, such as often found in rhabdomyolysis, which we'll talk about in class, or hemolysis, from blood transfusions, burns, chemotherapy, or crush injuries. And then the transmembrane shift of potassium. In other words, where potassium shifts out of the cells and into the extracellular space, which is often found in metabolic acidosis. As the potassium increases, the pH decreases, and diabetic ketoacidosis. Angiotensin-converting enzymes such as ACE inhibitors can inhibit aldosterone production, therefore decreasing sodium reabsorption and potassium excretion. So it's important to monitor serum potassium levels when your patients are on ACE inhibitors. Here are some of the signs and symptoms of hyperkalemia and the manifestations on the EKG monitor. In hyperkalemia, you'll often see that tall peaked T wave, or you'll see a wide QRS. Both of these are indicative of hyperkalemia if the monitor has been hooked up correctly. The nurse observes the patient with hyperkalemia for signs and symptoms of muscle weakness and arrhythmias. Signs and symptoms include bradycardia, hypotension, tall peaked T waves, wide QRS, V-fib, asystole, hyperactive bowel sounds, diarrhea, tingling and burning sensations followed by numbness and muscle twisting, which switches to flaccid paralysis. It can paralyze the respiratory system and the speech muscles. Treatment involves potassium restriction and/or medications. Emergency pharmacologic therapy in hyperkalemia includes loop diuretics, which cause potassium loss through the kidneys, but the patient needs to have good kidney function. Cation exchange resins, such as K-oxalate oral or enema. They bind with the potassium in the bowel and excrete in stools. If your patient is not able to take something PO, then K-oxalate enemas can be used. Regular insulin, IV, with glucose facilitates the uptake of glucose into the cell, which brings the potassium with it. And oftentimes you'll see a bag of D5 water mixed with a certain amount of regular insulin and ran slowly. Remember, regular insulin is the only insulin that can be administered IV. Calcium gluconate is cardioprotective, and it antagonizes potassium's effect and reverses EKG changes and decreases arrhythmia incidence. And then your beta-2 agonists like albuterol in large doses to facilitate potassium shifting into the cell. Remember, the emergency pharmacologic therapy treats the symptoms of hyperkalemia but does not treat the underlying cause. Therefore, the underlying cause needs to be identified and treated. Pop questions. A patient has been having frequent liquid diarrhea for the last 24 hours. A stool sample was sent to the laboratory to confirm whether this patient has Clostridium deficit or C. diff. The nurse should monitor the patient for which electrolyte imbalance. A. Potassium reabsorption primarily occurs through the renal system. However, approximately 10% of potassium regulation occurs in the gut or GI tract. Hypokalemia can result when clients experience significant diarrhea in situations such as C. diff. A nurse caring for a client who has a potassium level of 5.4. The nurse should assess the client for potassium levels can affect the heart, resulting in arrhythmias, such as VTAC or VFib. An EKG would indicate these findings. Constipation and slow respirations are signs of hypokalemia. Hypotension, not hypertension, is a sign of hyperkalemia. A patient is taking DIG or Lanoxin and is admitted with possible hypokalemia. Which of the following does the nurse realize might occur with this patient? A. The most common precipitating cause of DIG toxicity is the depletion of potassium stores. Thus, hypokalemia increases the risk of digitalis toxicity in patients who receive this drug for heart failure. So it's important to monitor these patients. A patient is diagnosed with hypokalemia. After reviewing the patient's current medications, which of the following problems might have contributed to the patient's health problem? C. Excess potassium loss through the kidneys is often caused by such meds as corticosteroids, potassium-wasting diuretics, amphotericin B, which is an anti-fungal. These medications cause retention of sodium and excretion of potassium, causing low levels of potassium. Calcium. Normal calcium levels in the body are 8.5 to 10.5. 99% of the body's calcium is located in the skeletal system. Calcium functions closely with phosphorus and magnesium. An important thing to remember is that absorption of dietary calcium requires the active form of vitamin D in the body. Two primary hormone regulators regulate calcium in your blood. One is parathyroid hormone, or PTH, which causes a release from when released from the parathyroid glands, produces more calcium if needed, and calcitonin, secreted by the thyroid gland when excess calcium is present. It causes a decreased plasma calcium levels by inhibiting bone reabsorption and vitamin D and intestinal uptake, and increasing kidney excretion of calcium in the urine. Remember, calcium is necessary for bone strength, as calcium is stored in the bones, muscle contraction, heart and skeletal muscles, nerve impulses, and blood clotting. And another important thing to remember that in pregnant women, it is not appropriate for these women to not have their calcium monitored. The fetus will take the calcium that's stored in the bones and pull it out of there first before taking the serum calcium level. Therefore, pregnant women need to be monitored carefully for their calcium intake and calcium stores. Hypocalcemia, less than 8.5 milligrams per deciliter. Causes are malabsorption, such as due to celiac sprue, Crohn's, pancreatitis, renal failure with polyuria, and malnutrition. Destruction of parathyroid glands, such as in thyroid surgery, lactose intolerance, or GI wound drainage. Assessment for hypocalcemia includes muscle spasms with tingling of the fingers and mouth, tetany, positive Trousseau sign, positive Shovstek sign, which is facial muscle twitching, monitor heart rate and rhythm, VTAC for torsades, respiratory difficulty, dyspnea, laryngospasm or stridor, hyperactive bowel sounds, osteoporosis, and check phosphorus levels. Interventions for hypocalcemia include calcium gluconate IV replacement, which also helps muscle spasm, magnesium sulfate, which decreases nerve response for tetany, vitamin D, which enhances absorption of the calcium, aluminum hydroxide or Amphigel, calcium acetate, calcium carbonate. These antacids decrease elevated phosphorus levels, and then skeletal muscle relaxants such as Parafon, Valium, or Robaxin for muscle spasms, and then Fosamax, which is prevention for hypocalcemia, and cardiac monitoring and respiratory status. Here's a slide that shows what Shovstack and Trousseau sign, and it's important to know these things. And again, how to assess for Trousseau sign and Shovstack sign. Hypercalcemia is when the serum calcium is above 10.5 milligrams per deciliter in the serum. Hypercalcemia causes excitable tissues to be less sensitive to their normal stimuli, thus requiring a stronger stimuli to function. This happens primarily from malignancy or hyperparathyroidism. Causes include overactivity in one or more of the 4 parathyroid glands, increased release of calcium from the bones with intestinal and renal calcium absorption, malignancies such as cancers of the breast, lung, prostate, and bone, use of thiazide diuretics which reduce urinary calcium excretion, immobility, prolonged non-weight bearing causes calcium release into the blood, and excessive intake of oral calcium or oral vitamin D. Remember, oral vitamin D is a fat-soluble vitamin, so as you take too much of it, it will build up in the system, and it is not excreted through the kidneys. Assessment for hypercalcemia includes bones, stones, groans, and moans. In other words, you'll see muscle weakness, bone pain, incoordination, anorexia, constipation, renal stones, monitor urine output for frequent urination, changes in level of consciousness such as confusion, lethargy, and fatigue, hypertension, EKG such as bradycardia and heart blocks, cardiac arrest, chest pain, possible dig level toxicities, signs and symptoms of blood clots or faster clotting times. Interventions include encouraging fluids, IV normal saline, the sodium increases the kidney excretion of calcium, and loop diuretics. Calcitonin sub-Q or IM inhibits bone resorption and increases bone density and osteoporosis, and cytotoxic antibiotics such as mithromycin or penicillamine, which inhibits bone reabsorption of calcium. In cases where the hypercalcemia is severe, dialysis may be indicated. When testing for Shovstack sign, where should the nurse tap the patient? Answer: the nurse should tap the client's facial nerve just below and anterior in front of the ear. A positive response is facial twitching of the mouth, nose, and cheek on the side being tested. Which patients are at risk for the development of hypercalcemia? Select all that apply. The answer: A, B, D, and E. Patients with malignancy are at risk for development of hypercalcemia due to destruction of bone or the production of hormone-like substances by the malignancy. Lithium and overuse of antacids can result in hypercalcemia. Hypercalcemia can result from hyperparathyroidism, which causes release of calcium from the bones, increased calcium absorption in the intestines, and the retention of calcium by the kidneys. Hypercalcemia can result from hyperparathyroidism, which causes release of calcium from the bones, increased calcium absorption in the intestines, and retention of calcium by the kidneys. And lithium and overuse of antacids can result in hypercalcemia. When caring for a patient diagnosed with hypocalcemia, which of the following should the nurse additionally assess in the patient? The patient diagnosed with hypocalcemia may also have high phosphorus or decreased magnesium levels, so it's important to monitor these other electrolytes. Phosphorus. The normal level of phosphorus is 2.5 to 4.5 milligrams per deciliter. Phosphorus is necessary for multiple physiological processes, such as the activation of vitamins and enzymes, the formation of adenosine triphosphate or ATP for energy within the cell. It's necessary for assisting in cell growth and metabolism and in regulating blood coagulation. Plasma levels of calcium and phosphorus exist in a balanced reciprocal relationship. In other words, if the calcium is high, the phosphorus will be low. Food sources of phosphorus include meats, fish, dairy products, and nuts. Here, this slide shows the inverse relation of calcium and phosphorus in the body. Hypophosphatemia, or a low serum phosphorus, less than 2.5, causes our hypercalcemia, malnutrition, starvation diets, alcoholism, renal failure, and hypoparathyroidism. Assessments includes assessing the patient for apprehension, confusion, changes in level of consciousness, monitor their cardiac output because it may be low, decrease respirations that are shallow, monitor for bleeding due to decreased platelet aggregation, weak muscles, which lead to rhabdomyolysis. Rhabdomyolysis is a condition caused by acute muscle breakdown that encourages large protein molecules to be stuck to get stuck in the kidneys, thereby decreasing urine output and blocking the ability of the kidneys to filter solutes. End-stage elevated phosphorus can result in seizures. Interventions include IV phosphorus, vitamin D, encourage phosphorus-rich foods such as fish, beef, chicken, pork, nuts, legumes, organ meat, and whole grains, and decrease calcium-rich foods. For pharmacological therapy for hypophosphatemia includes Nutriflos capsules or a Fleet's phosphosoda enema. High phosphorus levels increase cell hyperphosphatemia, or a serum phosphorus greater than 4.5. High phosphorus levels in the body increase cell excitability. Causes are renal failure, where the kidneys cannot excrete the phosphorus, hypoparathyroidism, some cancer treatments such as chemo, or tumor lysis syndrome. Signs and symptoms of elevated phosphorus include central nervous system changes such as muscle cramping, tingling secondary to low calcium levels, which may progress to tetany, delirium, and seizures. Soft tissue calcifications of calcium phosphate are noted, decreasing urine output, impaired vision, which produces palpitations. Interventions include monitoring the calcium and the phosphorus levels. Pharmacological interventions include phosphate-binding agents and antacids, such as aluminum hydroxide or alternagel, which combines with the phosphorus in the intestinal tract and allows it to be eliminated in the feces. Diet restriction is important, and again, in patients with elevated phosphorus levels that don't respond to medical and pharmacological therapy, dialysis may be indicated. A patient with a history of stomach ulcers is diagnosed with hypophosphatemia. Which of the following interventions should the nurse include in this patient's plan of care? Treatment of elevated phosphorus levels includes treating the underlying cause and promoting a high phosphate diet, especially milk if it is tolerated. Other foods high in phosphate are dried beans and peas, eggs, fish, organ meats, Brazil nuts and peanuts, poultry, seeds, and whole grains. A patient is diagnosed with elevated phosphorus. The nurse realizes that this patient might also have an imbalance of which of the following other electrolytes. Excessive serum phosphate levels cause few specific symptoms. However, the effects of high serum phosphate levels on nerves and muscles are more likely the result of hypocalcemia that ensues, which develops secondary to an elevated serum phosphorus level. Magnesium. The normal level of magnesium in the body is 1.3 to 2.3 milliequivalents per liter. Magnesium is critical for skeletal muscle contraction, carbohydrate metabolism, the formation of ATP, vitamin activation, and cell growth. Magnesium is stored in the bones and soft tissues, and normally magnesium inhibits or stops nerve impulse transmission. Low magnesium, or a magnesium less than 1.3, is often caused by alcoholism, tube feedings, or peripheral venous nutrition IV, malnutrition such as in celiac or Crohn's disease, drugs that promote magnesium loss such as diuretics, aminoglycoside antibiotics, cisplatin, which is a chemo drug, cyclosporin, and amphotericin B. Signs and symptoms of low magnesium are similar to hypocalcemia: hyperactive deep tendon reflexes, tetany, dysphagia, laryngeal stridor, tall T waves on the EKG, and depressed ST segment, premature ventricular contractions, VTAC, and a type of VTAC called torsades, confusion, psychosis and seizures. Hypocalcemia also accompanies low magnesium. Interventions for low magnesium include IV magnesium sulfate, IV or oral. If oral can be tolerated, it's given, but most likely if it's a problem where the patient is developing some cardiac symptoms, then the mag sulfate will be given IV at 1 to 2 grams per hour. It's given IV bolus over an hour, and carefully monitor the patient for any cardiac dysrhythmias that may ensue. Dietary changes for the patient with low magnesium include increasing green leafy vegetables, whole grains, seafood, milk, nuts, seeds, bananas, and cocoa. Again, monitor your patient for problems with heart activity and dysrhythmias, and bronchospasm. Hypermagnesemia, which is a magnesium level in the body of greater than 2.1 milliequivalents per liter. When magnesium excess occurs, excitable membranes are less excitable and need a stronger than normal stimulus to respond. Causes include renal failure because of the decrease of the kidney's ability to excrete magnesium, overuse of magnesium-containing acids, and laxatives. Signs and symptoms of elevated magnesium include bradycardia, decreased blood pressure, danger of cardiac arrest, weak respiratory muscles, wheezes from bronchospasms, drowsy and lethargic. Assessment includes frequent vital signs, an assessed respiratory rate and depth, and lung sounds. Interventions include loop diuretics and IV fluid, which promote excretion of magnesium, calcium gluconate, which reverses the cardiac effects, and avoid magnesium antacids. Limit meat, nuts, legumes, fish, vegetables, and whole grains in this case. The patient who has a serum magnesium level of 1.2 is being treated with dietary modification. Which foods should the nurse suggest for this patient? Select all that apply. A, B, and E. Serum magnesium levels of 1.2 suggest mild low magnesium, so this patient should be counseled to eat foods that are high in magnesium. Foods high in magnesium include green leafy vegetables, seafood, milk, bananas, citrus fruits, and chocolate. White rice and lean red meat are not included.